Can you hear me now? Can you hear me now, Betsy? Can you hear me now? Uh-oh.
You to ask questions as we go. This way we will understand some of the areas that you need additional information, and we'll look to follow up with you after the webinar. But today we do want to share some of the information we have and some of the strategies that we think will be helpful for organizations working through this pandemic and coming out on the other side. So with the next slide.
Thank you.
This, I'm not going to go through this slide in any detail, but kind of framing up where we are today, the patients that you're taking care of, and where some of the relief measures might come from. So most of you are used to thinking about your residents by payer class. We have our post-acute patients that are typically covered by Medicare and Medicare Advantage. We have our long-stay residents that may be covered by traditional Medicaid, may be part of the My Health Link program, or maybe getting covered under Healthy Michigan. And then, of course, we have our private pay and other residents that are either paying privately or covered under private insurance programs. So to date, we know that CMS has several relief measures in place already, some that they've rolled out, some they're in the process of rolling out. I've learned a little more even about the Medicare relief since this morning, so the slides aren't even updated, but we'll share that. But so we have our post-acute residents, then we have the long stay, and as Melissa indicated, we continue to be working through a process with the state to understand what relief mechanisms may be coming through related specifically to Medicaid, and there have been a couple that Pat is going to touch on. And then with respect to sort of private pay and other patients, There aren't a lot of opportunities for formal relief related to this population of residents, but we do have some ideas from some of these relief measures that really extend all across your patient population. So this kind of summarizes that, and we'll be referring back to these points as we go. Next. So I think what's important to understand out of the gate is that, unfortunately, in the midst of the challenge of trying to care for residents, manage staffing challenges, we are also, as an industry group, going to need to make sure that we have a method to account and track for costs that are related to this crisis and pandemic. And the reason that we're going to need to do that, it's still unclear today whether some of the relief measures coming from the federal government or whether any relief measures coming from the state government will require an accurate accounting of the costs that you incurred. We believe it's likely that some of the relief measures will require that. Some may be more generic and not required for you to account for them. But to be safe, it is essential that you have a methodology to do that. And one of the things that we're recommending is that, to the extent possible, it would be helpful for you to set up general ledger accounts that specifically identify supplies, for example, PP&E costs that you have to take care of your residents, additional housekeeping supplies, additional dietary supplies and costs associated with feeding residents in a different manner to practice social distancing. Any of the costs that you can identify separately, please do. We're also going to be able to track costs as they relate to per patient day costs, right? So another main area of cost that's increasing is payroll. And some of you may not even have your total payrolls increasing because your staffing has been fluctuating. So maybe your total payroll report wouldn't show a large increase, but it is a large increase when you compare that to the fact that the payroll might be the same, but the census has gone down. So on a per patient day cost, your costs actually have risen in the facility. So again, we want to make sure that you have good mechanisms to kind of understand the path and the trajectory of these items for you in your facility. And finally, one other area that was mentioned in the federal relief, acknowledgement that part of the cost of this pandemic has been lost revenue associated with not being able to have new post-acute patients, to not be able to admit long-term care residents, and also associated with the fact that some families took their residents home. So there's a lot of various factors at play here. So some of the things we're going to talk about today, and I'm going to talk through part of these with Pat. We also have the full HCAM team who's going to chime in on some of the areas on this slide that are more operational and regulatory. So we're going to discuss the 3-day hospital stay, for example, some of the changes around value-based purchasing, SNF quality reporting, the release delay on the new MDS, cost report due dates, survey relief, accelerated advance payment, and other impacts from the CARES Act. So let's start with the waiver of the 3-day hospital stay. That started effective with the declaration of the national emergency, and that will expire when that national state of emergency is rescinded. In general, the qualifications for that, patients that were evacuated from a nursing home in the emergency area, which would be anywhere, patients discharged from a hospital in order to provide care to more seriously ill patients, so patients that were dislocated from a hospital, And then finally, the category of patients who need SNF care as a result of the emergency, regardless of whether that individual was in a hospital or nursing home prior to the emergency. I think this is the provision of the waiver that has been, creates potentially the most opportunity to make sure that you are giving your residents any skilled care coverage with their Medicare benefit that they have coming to them. But I think it also is not really 100% clear in every regard. So I'm going to walk through a little more information on the following slides, and then we're going to ask Kathy to join in with some commentary and give you all a chance to ask questions. So with the waiver of the 3-day stay, and I know this has been presented as, as I mentioned, as an opportunity to cover residents and give them their Medicare benefit with avoiding a hospital, which, we've not wanted to send folks to the hospital. I know many facilities have been concerned about the risk of doing so, wanting to make sure that if they were covering folks that would be honored by CMS and intermediaries at a later date. It does provide an opportunity to use bed capacity that you have to serve individuals and to allow individuals to bypass a hospital stay. So to that end, as Linda mentioned, this is an opportunity for skilled nursing facilities to be partnering with assisted living and independent living facilities to understand when resident conditions across the continuum suggest that skilled care coverage is required based upon the patient conditions and would allow coverage of that individual upon transfer to your skilled nursing facility. Next slide, please. As part of this, an additional 100 days of Medicare benefits can be provided for care needed as a result of the pandemic. And this allows beneficiaries to receive an additional skilled stay without having to start a new benefit period. If you do have residents in your facility, so if we have billers on the webinar today, if you do have residents in your facility, when you submit those UB04 claims, they will need to be noted with the DR condition code so that CMS can be alerted that this is a patient that qualifies under the waiver that existed during the emergency period. Another aspect of this waiver is that time frame requirements for MDS assessments and transmission is waived with this waiver. Next slide. One of the things I think, and we'll open it up to questions in just a minute. These 3 goals have been the stated goals of the waiver policy. Freeing up hospital beds to maintain access for surging COVID-19 affected individuals, keeping emergency rooms and beds available for those individuals and not risking transmission risk if you sent your residents out, and being sure that we had a mechanism to be able to provide that coverage to SNF residents that needed skilled care without sending them to the hospital. So in connection with this, ACA has put together some additional FAQs. Kathy and Melissa, I'm not sure, have we had a chance to send those out to the members yet?
Yes. This is Kathy. Yes, they did go out early, I believe today's Thursday, I believe on Tuesday. And I'm happy to share them again with anybody who's interested.
They should also be available on our website because all our updates and material is put out there too. And there's just a red button, you click on that. That is open, you don't need to remember your password or anything. It's just open to whoever needs the information.
Yeah, you'll find a wealth of information and links to all sorts of, besides just the updates, all sorts of materials there that you can access as well.
Great. So with this, and Kathy, if you want to comment further, on the next slide, we have some additional information on the spell of illness rules. But just in terms of guidance on this in general, and Kathy can speak further to it, I think what we want to be sure that we're doing is documenting how we took this guidance in consideration with our residents at the time decisions were made, and that good clinical documentation will be very important for any potential review that might come down the road.
Yeah, Betsy, that you are right on, you're hitting it right on the nail on the head. And I think it's, you know, going back to talking about the goals of this waiver is to make sure that we create or have enough capacity on the hospital side to deal with those individuals who really need acute care. So with this waiver, it really opens the door for us to provide the care needed for individuals as much as we possibly can within the facility and be reimbursed and recognized for what we're doing. So those individuals who might start running a temp, and maybe we start doing IV hydration, we're looking at nebulizers, other types of nursing interventions and nursing and medical orders that would skill that individual. We can keep them in place, provide the care that's needed, and then bill on the Medicare A side for this individual. And as Betsy pointed out, with the spell of illness rules, that extends that window of time for eligibility. But again, as Betsy pointed out, it's very critical to make sure that you've got the clinical documentation to support the rationale for why that's extended.
Are there any questions right now on covering folks with the waiver, with the spell of illness that folks would like to have answered right now while we're on this topic? And certainly we can come back to it, but if you have a question here, feel free to type it in. Moving ahead then to the next topic, the value-based purchasing and the SNF quality reporting.
We have questions. It's just a matter of we can't see them up here.
Do we, okay. So let me take value-based purchasing right now. So CMS is offering administrative burden relief related to these two programs right now. There won't be any data collected from January 1 through June 20. It says 3020. It's not going to go out that far, a little typo there. But no data will be collected or used in any of the calculations for that time that impact the amount of your reimbursement that is held back related to value-based purchasing. I'm going to stop there for a minute because I see we do have a question here. Whether or not the additional 100 days of Medicare only relates to COVID-related illness. Kathy, do you want to take that one? Kathy? Did we lose HCAM?
Kathy, I think you're muted.
Okay, well, we'll come back to.
We're back, we're back.
Can you hear us?
Now we can, yes.
Okay, my apologies. We are having technical difficulties on our end. So if I am correct, the question was the spell of illness needing to be COVID related. And yes, the intent of these waivers is all directed towards addressing COVID. So For instance, if you have someone who's nearing their spell of illness and it's not related to COVID, then no, you would not want to extend that spell of illness. If, however, you're looking at an individual, if there is any correlation with COVID, then yes, you can.
So Kathy, that would include if there was any suspicion of COVID for that individual, correct? Any
Yes.
symptoms?
Yes, yes, absolutely. So if you are monitoring that individual and suspect signs and symptoms, or if there's COVID present and you've put that individual in isolation for whatever reason, that would count. So anything that you can tie back to the COVID pandemic, you can include.
Great, thank you. So on the next slide, this is some additional information about claims that are going to be excluded from the calculation of the all-cause readmission rate. And those will be claims from January 1, 2020 through June of 2020. And as you can see on the QRP, there's also some relief on submission of that information.
Betsy, we have one question on the back, kind of on the supplies. It says, are there recommendations of what specifically to include the documentation to support? It says charges, but I think examples of expenses. I think you listed them, like PPE would be gowns, masks, gloves, extra material needed, extra products you needed for cleaning, safety, supplies for nursing.
Right, and some of these I think might be able to be quantified separately easier, right? So maybe you were purchasing PP&E in large quantities in a way that hadn't been done before, and it's easy to take those invoices, segregate them. These were all incremental and COVID related, and you can put them in a separate account. For some of the other items, you are undoubtedly probably spending more on housekeeping, on dietary services. Even if you can't segregate those, if you're just making sure that at this time we're really having pretty tight accounting related to invoicing and having that information in our general ledger and in our accounting system, that will help us if we have to provide that information, because we'll be able to track the trends by showing how you're increasing spending so much per patient day during the pandemic time.
Thank you. There was a question about FMAP and that's coming to Medicaid. We will get to that later in the presentation, so just hold tight. We'll get your question answered.
Okay, another question. Does the 3-day waiver require the region or your local hospital to be actively fighting COVID, or is it effective for all facilities immediately?
I can take that one. This is Kathy. The 3-day waivers, the 1135 waiver on the 3-day hospital stay is considered what is known as a blanket waiver. It was put in place and covers every organization uniformly. It does need to be related to COVID. However, you do not need to do anything extra at either a personal level, an individual facility level, or at a state level to take advantage of that waiver. And Betsy, I don't know if there's anything else you want to add with that.
Nope, I think that's good. I do want to also add another point about the supply costs. And I think somebody might have indicated it on the chat. Andrea, I think that was you. Appreciate that. Making sure that you're including things like gloves, the respiratory products. The reason why segregating it is best if you can, because if you segregate these costs separately, it's easier to demonstrate how significantly the cost of these items changed during the pandemic period. Okay, next slide. On the MDS, we were all anxiously awaiting a new MDS form that was scheduled to be released on October 2020. That's been delayed. The intent of this new release was to reduce efforts related to having to report G data sets and GG and some of the implications for state acuity systems. So this now is delayed and we don't know what time frame it will be implemented. Next. Cost reporting due dates. Cost reports, they were due if you were a calendar year provider with a December 31 year end. They were going to be due on May 31st. They are now extended to July 31st. So 2-month extra time frame there. Next. Survey relief. Kathy, I'm going to ask you to talk about survey relief and some of the concerns with some of the ongoing infection control surveys and to give folks a brief update on this relief measure.
Okay, thank you, Betsy. As Betsy mentioned, and I'm sure all of you are aware, the Department of Licensing and Regulatory Affairs has suspended all routine surveys. So that means all annuals, all life safety surveys, any complaint surveys unless they reach the IJ level, and any revisits unless they are to an IJ level complaint survey during this state of emergency. With those suspended, however, they have started doing focused infection control surveys, and CMS put out guidelines regarding the infection control surveys, and along with kind of what I call a self-assessment tool. We did share that earlier, and you can find it on our website if you need to get a copy of it. The infection control surveys, for the most part, have been very brief. And when I say brief, I have heard from some as brief as a surveyor sitting in their car talking on a cell phone to the building and requesting remote access and in and out within about an hour. There have been some that have gone longer, as much as a full day and carrying over into a second day. But primarily what they are really focused in on looking at, do you have adequate infection control protocols and practices in place? Do you have the policies that you need in place, and are your staff following those policies? I can share that in my discussions with Larry Horvath, he has made it very clear that they will not cite for a lack of PPE when the provider is not able to obtain the needed supplies. I'm getting some mixed messages on that, and I actually had reached out to him earlier today to discuss that. So more to follow on that. But by and large, most of these surveys are fairly short and sweet, and the surveyors are back out the door. And the only thing I'll ask is, I have had a number of members share with me the outcomes of the surveys that they've had, and anybody that can continue to do that, it's very much appreciated. Thank you.
So on the assisted living side, with the surveys, the inspections, renewal licensing inspections have been put on hold. As much as can be done through desk review, the department is doing. Only very egregious special investigations would be done, but those would involve phone calls first to see if a visit would be necessary. Lara has been reaching out to HFAs and AFC and doing a wellness phone call. And so many of our members I've heard from already that have had those calls from their licensing consultants. Same is true on the Bureau of Fire Services and their inspections in the buildings. That has been delayed.
This is Kathy again. That Linda's comments brought up something else. I just want to talk about enforcement for a moment because that's been a topic of a lot of questions as well. Along with suspending the majority of the survey activity, CMS has also suspended the enforcement activity. So for instance, if you have a DPNA or a DDPNA in effect at the time that the suspension began back on March 23rd, that DPNA or DDPNA was suspended, and you could admit residents and be paid for their entire period of stay. Likewise, if you were under an enforcement action where you had CMPs being assessed on a per-day basis, those CMP assessments were suspended effective March 23rd. If you are in a current open window and you have been waiting for a revisit that is not tied to an IJ level concern, I would recommend that you reach out to your survey manager and request a desk review. CMS has directed the state agencies that as much as absolute possible, they are to clear as many of the open windows by desk review. So anything with an F or lower in scope and severity, and anything that is not a substandard quality of care should be allowed to be reviewed and cleared through desk review. So, and again, if anybody has questions on requesting or submitting materials for that, or whether or not their survey would qualify, give me a heads up and I'd be happy to help. Thank you.
One question has come through, does HCAM have the numbers on how the focused IP surveys are going in Michigan? How many citations, fines, things like that? I don't think we've been able to track that during this process.
No, not as of yet. I have seen some of the EPOC notifications come through, but many of those still do not have a 2567 even completed as of yet. I will be tracking those in the future, and we'll report out on those with the other standard survey reporting probably beginning with next month. So as I can actually access that information, we'll start reporting out on it.
Two questions, Betsy, I'll let you take these two. Both of them are, has there been any activity on delaying the Medicaid cost report for the December year ends like Medicare has done?
So the short answer to that is unfortunately no. The state has held their ground on the filing of those cost reports at May 31st for now. One of the concerns that the state had was that if cost reports weren't filed on time, they indicated that it might be more difficult for them to meet the timelines of audit that are outlined in Public Act 612, which was the legislation passed last year to require the state to audit the cost reports on a certain timeline. We have pointed out to the department that that really is not an acceptable reason because Public Act 612 starts the clock running once the department receives and accepts a cost report. So their clock for the timeline of audit could start ticking not until after the cost report was filed. So they really aren't impacted if an extension is granted, let's say even 30 days, if not the 60 days that Medicare has provided. So Pat and the HCAM team, we continue to advocate to have that deadline extended. I think also part of the initial hesitancy by the department was not knowing how long the pandemic would go on. I think when we hear from the governor this afternoon and get an update on the shelter in place and other provisions, I'm confident we'll be back to the drawing board to ask again next week. But as of right now, nothing has happened.
Thanks, Betsy. And yes, HCAM continues to have that request in at the department at this time.
Some of you may also be experiencing Medicaid audits that had been scheduled or were in process prior to the pandemic. We have had some cooperation by the department in allowing providers to opt out of that, but there has been some hesitancy on their part to issue a blanket, we're going to cease those or extend them. But if you are having, significant difficulty in working through that, please let Pat know and she can help you talk to the department.
Yeah, and as follow up on that too with Medicare, if you're getting their medical reviews have been paused, the ADR process for extra information has been paused, and if I can remember rightly, they also went back, get my notes here, any bill that was denied because the ADR was not available, I think it was March 1st, will now be repaid, go back to the system, they'll pay it and let it go. Unless you had filed an appeal, then it will go through the appeal process. So check your ADRs that are coming from Medicare.
Okay, next slide. So I want to talk a little bit about accelerated and advanced payments. I think you can go to the next slide right now, Rhonda, thank you. So what these are, advanced or accelerated payments is the term. So this is actually something that has always been in statute, which I have to admit, even as a seasoned veteran reimbursement expert, is not something that I was familiar with until this pandemic. But these accelerated or advanced payments essentially are opportunities to get Medicare loans. And so the loans are granted by Medicare and they're paid back against future Medicare claims. So as part of the pandemic, CMS made the determination that qualifying for these loans would essentially be across the board, except for a couple of exceptions. The provider can't be in bankruptcy. You have to have billed Medicare for claims within the last 6 months. You can't be under an active medical review or program integrity investigation. Now I want to pause there. Program integrity would be anybody who's under corporate integrity agreements. Under active medical review, I'm not confident with elaborating on what the definition is of this. So, as far as I know, most everybody that has applied, in fact, I don't know that of anybody that hasn't had theirs approved for this reason or related to this reason. I don't think it's intended to be a typical documentation review. That's not what active medical review, I think, speaks to. So if anybody on the webinar has anything in addition to offer to that, but really our experience over this first week has been that CMS is moving very quickly to approve these.
I'll add in, CMS has put out for these payments that they have already, and this was as of I think yesterday, there was $34 billion had been put out to healthcare providers. So as Betsy's saying, it's a quick process to get your loan.
So the amount of the loan, and if you want to go to the next slide, the amount of the loan that you can get is 3 months worth of Medicare for skilled nursing facility providers. Hospitals were entitled to get an advance of 6 months worth of payments. So this is an interest-free loan and an ability to get this cash to use for some of your increased COVID-related expenditures while permanent funding mechanisms for these costs get put into place. And so that's the way I like to think about these programs. So you're going to have them, you're going to have to start repaying them after 120 calendar days. So that's 4 months. And the way you're going to repay them principally is that 4 months from now, claims that are issued are going to be applied against the loan. You can see we also have a bullet point on here for providers who receive periodic interim payments. There may be a small amount of providers who get those. That's the same as like the MIP program that we have here in Michigan. Providers can access PIP at the federal level. And typically, this is used in states where they don't pay coinsurance. So we don't have a lot of that here in Michigan. Other states you would. So for the majority of people, you're gonna start paying this back in 4 months. Next slide, please. So 4 months from now, the recoupement's going to begin. You're going to continue to bill claims during this 4-month period, okay? So you've gotten fronted 4 months worth of cash. That doesn't mean, or excuse me, 3 months worth of cash. Doesn't mean that more cash isn't coming, because you'll continue to bill and collect and those funds will come in. Now, albeit those funds might be less than you are used to receiving, because we are seeing a significant reduction in impact in the post-acute utilization. But at the end of the 120 days, then when claims are processed by your fiscal intermediary, that claim won't result in cash. It will be put against the loan that you've received from Medicare. So one thing I want to make sure that everybody's really thinking about is making sure that you are keeping track of this money. Some folks have actually moved it into a separate bank account so that they could monitor how much of it they were using to fund their operations. I don't know that that's necessary, but it certainly can't hurt. It should be recorded as a liability in your financial statements so that it's a reminder that you're going to be paying it back. It is a current liability because it's going to start being paid back in 4 months. So again, what I think makes most sense is that all providers should be doing a cash flow projection for their organization during and post the pandemic period that would contemplate cash advances like this one, the one you receive from Medicaid that Pat is going to talk about, so that you can incorporate these various cash flow mechanisms and then also begin to incorporate in your cash flow projections how your normal monthly cash is going to be reduced because your census is lower. And so if you do this cash flow projection, it's going to help you understand how many months out it's going to take you until things have stabilized and returned to normal in your organization. And if you do this type of cash flow projection, it'll also help you understand maybe what census level it's going to take to get back to normal. So we can talk about that again more in a minute. As far as requesting the loan, if you haven't done it yet, these are the links to the specific websites for the intermediaries. Next slide. Each intermediary has a little bit of a different form. One of the intermediaries forms, I think it's NGS, asks for you to actually provide information about your financial circumstances. You don't need to do that. It's asking for that simply because this form is available to everyone on an ongoing basis, and that you could use this form if you had a financial need in the future. For now, all you would need to do is indicate it that it's related to the COVID-19 pandemic.
One comment, Betsy, you have to do some of the MACs are requiring that you do a Part A and Part B separate application.
Thank you.
And some are letting you do one application. So you want to go to your MAC website and find out what they exactly want.
Good point. So in terms of helping you, if you haven't filled this out either, you know, you're allowed to access up to 3 months if you take out, you know, an old PSNR to help you estimate what that amount is. that's the similar methodology that the intermediary will be using to decide if your request is reasonable. Okay, next slide. Okay, next one. Talked about that. Okay, I think we've already talked a little bit about this, managing the cash flows. So I've mentioned a few things you'd want to incorporate in here. There's also a couple of other provisions from the CARES Act that offer opportunities for additional cash flow relief. So the first, I think we have additional slides on these. So next slide, please. Okay, sequestration. So as all of you know, there's a 2% haircut that you all take on your Medicare claims that they hold back when you are paid. For all claims paid between May 1st and December 31st, that 2% will be suspended, meaning you'll be getting your full reimbursement. It's actually for the claims paid between this time frame, irrespective of dates of service. So it's claims that are processed and paid during that time frame. Now let's spend a little bit of time talking about this $100 billion fund.
Can we butt in a minute, Betsy?
Of course.
I hope everybody bears with us. We're trying to answer questions and keep it moving, and we know some of the answers are coming later, but we'll try to get them as we come up on them. So we're doing this as quickly and as efficiently as possible. The question became in the hospital admission, the 3877, and the paperwork that needs to go with that. I think that got waived by CMS as a blanket waiver. No, CMS put out, what, 1135 blanket waivers. Kathy mentioned those earlier. And within those contents, they waived a lot of the paper requirements. And we'll talk a little bit later. Michigan also got a 1135 waiver approved end of last week. They didn't have to ask for the blanket waivers because they were already there. So they did include a few other things. We'll get to those when we get to Medicaid. Okay. So let's start with the $100 billion. That sounds good to me.
Okay, this is Kathy. I'm going to jump in because there was one other question that we didn't get answered yet as well, and that was whether the infection control surveys will impact the CMS 5-star survey domain if a citation is issued. CMS has not provided that clarity as of yet, but if I were to hazard a guess, I would say yes, because if in reviewing the enforcement letters that are coming out, they're very clear in the enforcement letters that any enforcement action that is tied to that survey outcome is suspended until the end of the state of emergency. So if they are tying enforcement actions to those surveys, I would assume, and you guys all know what assume means, but I would assume at that point in time, then yes, any points or any actions from that survey would count in the 5-star calculations. And if we can get some clarity from CMS on that, I will share it. All right, thank you, Betsy.
Thank you, Kathy. So now on to the $100 billion fund. So most of you probably have seen this talked about in the stimulus package that $100 billion is supposed to be available for eligible healthcare providers. So essentially, and I don't know, maybe some of you saw Seema Verma on TV, I think it was 2 nights ago at the evening press conference from the White House, and she talked about rolling out these stimulus funds, essentially kind of in a, I will call it a 3 or 4 part process. So her first relief measure that she talked about were these loans, the Medicare accelerated and advanced payments that we just talked about. And she talked about the fact that those were processed and paid out very quickly. And I think she may have indicated that the total that was paid out under that was $34 billion, although don't quote me on that, that may not have been correct. But that was phase one of the funding relief, really to get cash in the hands of providers to use to help cover the additional expenditures. And again, this is loan, so it's not actual relief because it's a loan. So phase two, she talked about, was a process that would be rolled out to get grants. And she specifically used the word grants and indicated that this would be revenue, funds that would not need to be returned. And so these grants were phase two to be rolled out to providers and paid sometime next week. Excuse me. So under this process, and we've been learning a little more about this over the last couple of days from ACA, our understanding today is that while I still can't tell you what number you're going to get, I can tell you that it's assured that skilled nursing facility providers are included in this segment of relief, and that we contemplate a process where each skilled nursing facility will go to a portal that CMS is establishing to register with your Medicare provider number and the bank account number that you currently receive your Medicare payments at. And after that is done, CMS is going to link to your Medicare cost report from last year, the last one that you filed, and use a formula to provide a grant to your organization based upon Medicare Part A and Part B costs from the prior cost report. Now, unfortunately, I don't have details on it's 10% of last year's cost, 20%, 30%. I've heard varying numbers, so I don't know which one is true, so I'm not gonna throw a guess out there. We believe from ACA that the final directions will be out by the end of this week, so hopefully by tomorrow we'll know what that number is. But this amount will be a grant. Now, one additional caveat, however, with the grant that was mentioned by ACA today is they're not certain if it will require reconciliation to expenditures and a potential repayment if not spent. Thus, the emphasis at the start of the session on really making sure accounting records are not slipping during the pandemic and in fact are more detailed than ever. So again, we don't know if that's 100% true, but ACA really wants its member facilities to plan for having to do that. Given that we also hope for some Medicaid relief, and because we have a Medicaid cost report, Medicaid cost-based reimbursement system, it's likely we could potentially have to provide details for Medicaid as well. So I'm being asked to repeat what I said on reconciliation, so let me back up. I know it's a little bit confusing. So let's say it comes out tomorrow and you get to go online, like I mentioned, register your SNF, and Medicare sends you a check for $100,000 based upon this formula. There's a chance there's never any settling up for that $100,000 and it's just a permanent grant. But there's also still a chance that that 100 grand would have to be reconciled to your actual COVID related expenses and lost revenue. That's not clear as of today at 1 when I got on this webinar. So let's keep that in mind. I'm going to pause there in case there's more questions on that. Let me look.
I want to add an emphasis, Betsy, gets back to what we started with was about tracking all of your costs. And this is part of the reason. If they come later and they need it, you need to have it there. And Medicaid could be asking for this too, anything. So
yeah, there's also, There's also a question on calculating loss of revenue. That one is more difficult, right? I think a good measure of loss of revenue is tracking census compared to average daily rates. So most facilities have seen over the last couple of weeks a significant drop in post-acute utilization. Hospitals have had bans on elective surgeries. Hospitals have been at full capacity with COVID. Families have been trying to keep loved ones at home. So all of those things have resulted in census fluctuations. So having census data as available to help with that calculation, and as soon as this final instructions do become clear, we will provide more guidance. But today we're trying to give you the latest and greatest that we know as of 1 o'clock today. Now, in addition, again, going back to what Seema had indicated. So she indicated her second form of relief was going to be with these automatic payments to providers, the grants. Then third, she acknowledged that there are some providers, she referred to children's hospitals and nursing homes, that have experienced significant impact that probably is larger than what you can measure by just looking at Medicare history, because their Medicare volumes aren't significant like they are in a hospital. So she indicated that there would be continued analysis of what is needed to be done there with additional funds coming. So I found that very encouraging listening to her on that topic. And then finally, she emphasized the need to help healthcare facilities that are operating in and around hotspots of the pandemic in the country, which suggests, again, encouragement for many of our member facilities that have been very, very close and in the hot spot. So that's what we know as of today. Okay, next slide. So a couple of other things I want to bring up here on the SBA loan. So there is an ability to get an SBA loan, and SBA stands for Small Business Association loan. These are part of the Paycheck Protection Program, which really offered folks an opportunity to access relief under one of two options. Either getting one of these SBA loans that has a forgivable aspect to it, or taking advantage of the opportunity to defer payroll taxes. And we have that listed on the next slide. To be able to take advantage of the loan, the applicant must have less than 500 employees. That test is done using common control. So if you're from an organization that has more than one facility, you have to look at all the facilities under common control to see if you would qualify. These loans, banks are very furiously trying to process these loans in connection with small business associations this week. You know, we're told that most banks are not processing these loans except for their existing customers. So if you feel you can apply for this, reach out to a banker that you're currently doing business with, and it's your best opportunity to get access to one of these loans. At this point, I don't know too much about the other two items that are listed here, the Child Care Act, or this $200 million to CMS that was kind of vague. I really wasn't sure what this was related to. So Pat, I think maybe this is something we can put on a list for further research to let members know.
Yep, we will do that, yeah, and I think the $200 million prepare for response to COVID and that Some of that money may be for state governments to operate their programs, but yeah, you're right, there's not much detail out on that. The child care for the families, we've advocated if they could reopen schools for child care centers and that we need. Some other states are doing that. We haven't seen much on how that will work either, but yep, I will note that.
Thank you. And also, I just had someone mention that you can work for the payroll protection program with credit unions as well. So thank you for mentioning that. So banks or credit unions on that. One of the things also that I did hear from ACA today, I had a couple of folks ask me about FEMA funds and whether or not there would be the ability for SNFs to access FEMA funds. So ACA, as soon as this stimulus money is nailed down and they'll be issuing how you're going to access it, they're also going to put out a tool that helps providers understand all the various things that are available federally, because some of them really do, participation in one blocks you from another. So I talked about this SBA loan eligibility and the Payroll Protection Act deferring the payroll taxes. So let me talk about that. The deferring of the payroll taxes is to defer the employer portion of the payroll tax. So it is a mutually exclusive option with taking advantage of one of these SBA loans. However, if you are waiting for your SBA loan and you have a payroll come up, you can take advantage of deferring the payroll tax while you wait for the loan. So you can take advantage of both, but not simultaneously. Similarly then, back to the FEMA money, I was informed by ACA that any FEMA money would make you ineligible for the overall CMS stimulus money. So this process I just described, where you're going to get a grant, that is available to providers who choose that. If you chose FEMA funds, you wouldn't be able to access the CMS. So those two are mutually exclusive.
I have a little information on the FEMA grant. There was a letter sent out on April 2nd by the State of Michigan Department of State Police on that. These FEMA grants are available to state governments, local governments, and private nonprofit organizations, cooperatives, hospitals, schools, churches, Indian tribal governments. We will put that in the next update. We'll put the link to this letter and the information. They do have a website, and I can't find it quickly, but we'll put it out in the next one either today or tomorrow.
One other question here, there was if we had any further detail on the affinity or 500 employee rules, and if the entities are owned in different partnerships. The different partnerships, if they are under related or common control, mean they have to be counted. So even if you have partial common ownership, I think that would preclude you from taking advantage of it. But I would recommend that you get that final answer from your banker, because bankers are the ones who have really been studying these provisions of the Act to make sure that they're working to get these loans in accordance with the regulations. So yes, to reiterate, wait, you're saying, so the MyHand state release on FEMA, this is something we have already, the MyHand, right?
MyHand, the Health Information Network?
Yeah, MyHand is it's a health alert network.
Yeah, it's a health alert network. The health alert network?
Yeah, it's generally used to share pertinent clinical information.
It probably sent out this letter from the state police.
Yeah.
Because it's somewhat connected to them, but under the Special Operations Center for Pandemic.
Right, but I think the question is, and please type it again if we're not hitting on this right, But the question is that the MyHand, I don't believe, would make any provider ineligible for this CMS stimulus money I'm talking about now. FEMA has new money available to individual organizations as a result of COVID. And so if you access the FEMA COVID money, then you wouldn't be able to get the CMS COVID money.
Yeah, the federal government's willing to pay you once. So you can access, you might want to see which one gives you the better benefit, but.
I do have a question on
Do you have another question that we need to answer?
the 500 employee rules. Roger, no.
There's another question on the 500 employee rules, or did you answer that?
Yeah,
I
did
think
you-
that's the one that I answered. Just.
Okay, thank you.
Okay.
So I think we're up to date on questions, although there was a question about the telehealth. And so we did not have anything in this presentation about telehealth and how you would bill for that, but that is certainly something that we can provide information in an upcoming pulse about, and details about the changes that were made there. Had you put anything out already, HCAM crew, that we could talk about now?
Yeah, this is Kathy. Yes, actually, originally CMS came out with a very generic toolkit on telehealth when they first included this in the waiver. And then, I think about a week later, maybe 10 days later, CMS issued a toolkit that was directed specifically for long-term care, and that both of those were shared, and you should be able to find the toolkit on our website as well. But the bottom line with the telehealth is that the services have been expanded to allow telehealth visits to be utilized for typical direct provider resident visits. In addition to expanding the use of telehealth and being able to bill for those visits, and let me back up for a minute, because previously you could not use or you could not bill for a telehealth visit more than once a month. Now you can utilize expanded billing. So if you are seeing an individual, and when I say you, I mean a provider is seeing a resident, say maybe they're seeing them twice or 3 times during that month, they can bill for each of those visits now. And there is billing guidance in that toolkit as well. Along with expanding the use of telehealth, specifically for the crisis situation, CMS has also loosened the criteria on what type of telehealth constitutes a appropriate visit. Typically, in a telehealth setting, you have to have, how do I explain it? The technology that's used has to be secure. So in order to uphold HIPAA regulations, and because of the pandemic, they've allowed the use of technology such as FaceTime or some of the other face-to-face, the virtual audio conference type apps that can be used that are not necessarily secure. I still would highly, highly recommend that if you have access to some type of internet security that you can use if you are using telehealth, to please do so. We still, regardless of the crisis that we're in, we still need as much as absolutely possible to adhere to all HIPAA regulations and resident security, patient medical record security.
So a couple more add-on questions while we're talking about telehealth. Kathy, are you aware if telehealth has been expanded to include therapy visits?
That is a great question. To my knowledge, it is for a provider, a medical provider, for a visit or a medical exam with a resident or patient, and not necessarily for providing therapy. I think with the therapy, you know, there's options for provision of therapy, but I don't believe the telehealth option is available, at least from a billing standpoint as well.
Thank you. 2 other questions or comments. So thank you. There's a very helpful FAQ link on the SBA Payroll Protection Program loans. So for all of you participating and looking at the screen, the SBA is updating this site regularly. You can see the link. And HCAM crew, perhaps you could include this in a future pulse in case folks are on the phone and don't have a screen in front of them.
Yep, absolutely.
And then finally, another question. We receive an SBA loan and part of it is forgiven. Would this quote unquote income have to be offset on the Medicaid cost report? I think the answer is no, but Pat and I will do some additional research and put that out as well. All good questions, so keep them coming here. Okay, next slide. Next slide. One more. The slide previous had some other information on taxes and income taxes that I don't have a lot of information on, but I think the takeaway there is to talk to your own individual tax accountant to make sure you understand any implications for taxation for your entities during this pandemic. Pat, I think you were going to pick it up here on Medicare Advantage and Medicaid.
Yep, sure will, Betsy. Thank you. Medicare Advantage plans, as you know, they run a little different than the Medicare fee-for-service. Each of their plans, like we say, the first thing is they can make their own decision on some of these waivers and changes and sequestration and all that. They can make their own decisions on it. Most Medicare Advantage plans had already had the 3-day waiver, which was something that was available to these types of plans. So that shouldn't be a big issue. You do get a negotiated rate with them. The question becomes sequestration, does it apply? From what I've read that they were being withheld from those plans, they should be getting the money back. Circle back to them and you may have to renegotiate your rate on what's happening with that and ask them about that. As each plan can do their own thing, the best advice is to go to if you have a contact in the plan, or go to their websites. They're posting a lot of the information there. A lot of the plans have already waived any kind of co-payments in that. We know Blue Cross Blue Shield did, Humana did, Cigna did, and I'm sure there's other ones. I got Dash. I found that out by just going to their websites. And a couple of them I'd been hinted to that this was being done. You can find it there. That's been permitted by Medicare. CMS has said that's all right. So you should see some of that. The other big one here in Michigan is NaviHealth and what they're doing. I got from NaviHealth today, they do already have the waiver of the 3-day, where NaviHealth works with Blue Cross and Blue Cross Blue Shield, Blue Care Network, that they had already had the 3-day waiver on the hospital stay. NaviHealth sent out a day or so ago, I just got the information today, they sent out to their providers saying that they were also looking, and we had asked them about prior authorization in that. And they have a streamlined process for people moving from an acute care setting into a skilled setting and allowing the authorization for the transfer rather quickly, asking for clinical documentation due to them, NaviHealth that is, within 72 hours of admission. They have 3 people for the different areas: Northern Detroit, Flint, Saginaw, Western Michigan, Northern Lower UP, Southeast Michigan, Lansing, and Jackson. Individual people that you can contact on what's going on. So they are trying to be somewhat flexible. We want them to waive all prior authorizations, but we didn't quite get that far, but I think they're trying to work with it. We will put this information out in our next update that goes out from HCAM. And you should have gotten a notice from NaviHealth, like I said, I think a day or so ago. Next slide. Any questions? Next slide is on Medicaid fee-for-service, we put it. We'll talk about the Medicare Healthy Michigan and the My HealthLink plans a little bit later. Excuse me. One, we want to talk about Medicaid on April 2nd, released cash advance payments to Medicaid providers. Just pretty much all Medicaid providers received the money. There was a group of about 10, 12 providers that did not. Primarily, they were ones with didn't have a census data, so they did use census data from your 2019 cost reports and 2018 cost reports, I think it was. So if they didn't have those, they didn't give you a payment. And there was a group of providers in between a change of ownership, and they did not have a NPI number, so they had no number to pay them under, so they were unable to do that. This is a cash advance. We talked about the Medicare accelerated payment being a cash advance and having to be paid back. This is a cash advance. Now, I know originally HCAM had put out that it was connected with the QAS, but it is not. It's a cash advance on your Medicaid payment. What it was, there was a pool of $15 million that the state was able to come up with. Now, Medicaid, like Melissa talked a little bit in the beginning, unfortunately our state of Michigan, because so many people are unemployed and not working, their revenue has gone down significantly, and actually the state of Michigan has an extreme cash flow problem. We can all relate to that. Now, what does that mean for us? They did find the $15 million pot and said that they could give that out. Like I said, everybody got that payment on April 2nd, a week ago from today. Those are loans. Those payments will go against your settlement for this year. So in December, end of this year, you file your cost report. They're going to do an initial settlement. They'll have paid you on your claim adjustments. They paid this loan payment as a gross adjustment. That will get included with those payments as payment from Medicaid. So it is a loan. It's a cash advance if you want to think of it that way. Just like the accelerated payments for Medicare, except the payback will not be done until the reconciliation or the initial settlement, which if you're talking 2020, those cost reports for the bulk of providers or December year ends wouldn't be due until May of 2021. So you have that money for this time. The next issue we wanted to talk about was Medicaid's Bulletin 2016 on options to use for your bed occupancy, different things you can do with beds, allowing to get capacity out there. What they're allowing you to do under Medicaid, they said that in this policy, and Medicaid actually put it in their 1135 waiver to get approval for that, Medicaid residents could be placed in Medicare certified beds. So if you have a Medicare certified unit, you can put a Medicaid person in there without submitting a request for Medicaid bed certification or anything. You can just do it. Those facilities with non-available bed plans can use these beds to, you can reopen these beds if you would like. MSA put out that policy, MSA 2016, and basically stating that you can use these beds. You just need to notify the rate setting group that this is what you're doing. And it talked a little bit about how it would deal with your plan. We got a clarity as of today on what happens when the pandemic is over, because yes, it will end. And then if you want to put those beds back in your non-available bed plan or not. And what Medicaid has told us is the facility could return, if you had 20 beds, you took 10 out and used them, or used 20 and you want to put 10 back. So you don't have to go to exactly the same plan you had before, but you can do a modification of it. If you want to return some of the non-available bed service without negating the plan, you just need to notify the audit review and rate setting section within 30 days of doing that. If facilities then could return the non-available beds to a non-available bed designation after the pandemic, you just need to notify Medicaid program again what you're doing. These changes will have to be tracked on your Medicaid cost report. Under Worksheet B, there's an area where you can show these beds were in or out of service. So you are able to do that. This is to create a better capacity within our facilities, and which was needed greatly.
There's a couple questions.
Got a couple questions? Okay.
Can you read them?
Yep. Let's see. One is this, sorry to go back to this. The FICA employer deferral, is there an application that needs to be filed or submitted? If yes, to whom? What is the procedures for FICA deferral? I think that's just a flat-out deferral of the payroll taxes, and they get paid back in 2021 and 2022?
That's correct. And we have some extensive articles on this on our website, Pat. So if you want to, I can give you those links and you can put them in the Pulse. There's the payroll tax deferral. There's information about a payroll credit for required sick leave if someone had to take family leave, and an employee retention credit that could apply. So it's pretty comprehensive information here. I can give you that link and you can.
Yeah, send us the link and we'll put that
Pulse.
out in one of our updates. We'll also put it on to our website. The other question, can you confirm if the stimulus checks to cannot be counted against the asset limit for Medicaid beneficiaries for a year? Actually, we found out some information on that. We're getting stuff as we go. Kathy and I were talking about that a little earlier. And Kathy Googled. Internet's fantastic, I tell you.
Yeah.
She Googled this, and what we found out is what it says, and pardon for just reading it to you, but it's easier than trying to re-explain it. And this is coming from Social Security Administration. It says the CARES Act provides for one-time direct payments to individuals, including Social Security beneficiaries, individuals earning, and it gives you the dollar amounts in that. The basic Medicaid rule for nursing home residents is that they must pay all of their income minus a certain deduction to the nursing home. If the stimulus payment were considered income, it would likely have to go straight to the nursing home, yes. In the most states, Medicaid recipients cannot have more than $2,000 in cash assets. There was also concern that the stimulus payments could put many recipients over the asset limit. There was a blog that was written by the Commissioner of Social Security Administration clarifying that SSA will not consider stimulus payments as income for supplemental security insurance recipients, and the payments will be excluded from resources for 12 months. Because state Medicaid programs cannot impose eligibility requirements that are stricter than SSI requirements, the payments should not affect Medicaid eligibility. I have sent a request into Medicaid eligibility also. And we got an answer just minutes ago, is from Bridget Heffron, which I think if you ever went to the billing seminar, she comes. She's a very interesting speaker. She said her understanding as of today is that most people in the nursing homes are receiving RSDI, or taxpayers will receive a check, and currently the understanding is that they will be an excluded asset for 12 months, just like I said. The information is subject to change. The COVID policies are rapidly changing right now. So she's repeating what we just read. We will also put this information in the next update, and also that it shouldn't impact that. There's another little caveat that was in the, I don't know which stimulus act anymore, that said that Medicaid cannot kick someone off of the Medicaid eligibility if the redetermination isn't done on time, and that the only reasons they could change, if they want to get the FMAP from the Fed, the only reason they can change it is if they passed away, or they moved to another state, or they voluntarily asked to be withdrawn from Medicaid. Otherwise, they cannot change it. As of March I'd seen March 18th, 2020, and I've also seen March 16th. So they can't change people, they can't change criteria or anything. What happened at that time, to get the stimulus money, the state has to operate the program the way it is. Is there any other question? I think we got that.
I think we got it.
So the next topic was eligibility. And I think we kind of went through all that, the redeterminations and everything that's going on. We also see that Michigan in their 1135 waiver had asked for if there could be the LOCDs being done telephonically. They even referred to them being done on cell phones and that. I'm assuming they got that approved. We've seen the initial 1135 waiver. I haven't seen the approved letter.
No, not
It
yet.
says it's approved, but I haven't seen the detail in it. I'm assuming that will come through. That makes sense since they don't want any face-to-face. PASSAR was given as a blanket one that you didn't have to do those items, and you could delay some of the PASSAR, especially the level 2s, until it was appropriate, which is a pretty open spot. We move on. Next thing I had on Medicaid fee-for-service were audits and cost reports. I think Betsy already touched on both of these. We don't know about cost reports for the December 2019s being delayed yet. We're waiting. They have not answered us at Medicaid, but audits have been postponed. The audit department is trying to work with folks. They were very cognizant when we talked to them that they understood that at the facilities, it's all hands on deck, taking care of the residents, that some of these things are just not going to happen. Next slide. Medicaid Health Link and health plans. HCAM has asked for them to somehow expedite the 45-day skilled level care. When you're in a Medicaid health plan like Healthy Michigan, Medicaid health plan, you've had skilled services for 45 days. The health plan has to initiate the change back to fee-for-service. We've asked if that could be changed in that a nursing facility could, and do it almost on an automatic basis once 45 days have been reached, because the health plan that's their end of their obligation under the benefits that they are providing. We have not heard for sure if that's going to be done, but we will keep pursuing that. My Health Link, we haven't heard really much news on that at all. If you have any negotiated rates on that, especially for your Medicare portion, sequestration would have given them money back too. I would suggest going back to them and asking them if there's anything you need to adjust, especially if you negotiated a rate and now it's not covering the extra costs you're having to take care of. If we find out any more from My Health Link directly, we'll let you know. What's next?
Federal stimulus funds.
Next slide. Federal stimulus. This kind of just a quick recap, not to go through all of it, but just, I don't know about you, but it's getting kind of confusing on all these stimuluses and what they are. And we're getting kind of short to the end of the time, so I'll go real quick. I just gave you the names of the different programs, the first round, second round, third round, and like it's already been initiated that there could be a fourth round. So I'll keep moving along. The Michigan COVID funds, the next slide. Oh, it's there, don't move. Okay. Public Act 66 and 67, there was a total of about $150 million. It was 3 different funds that were put together by the state legislature. There was primarily one fund that was $50 million that was supposed to be available to all healthcare providers. We are asking for $15 million of that money to help come to us. How we came up with that number, which happens to coincide with the advance payment, was they were asking us what we needed for a 2-week cash flow, and that was the $15 million. That money has not been given out yet. There's been claims that it's been given to someone else, like the hospitals got everything. No, our understanding is that the legislature has not acted on that. We are in contact with our state representatives, senators and representatives, daily and talking to the the Speaker of the House and the Senate Majority Leader on what part is our funds. There is no commitments at this time. Let's see, authorized expenditures. Federal funds, there is a thing, if there are any federal funds coming, that those expenditures had to be out within 90 days of March 25th. To reiterate, and I think we've done this a couple times already, and if you see the news at all, there's billions and billions coming to all of the states, and the federal government is coming with lots of money. The states are looking for money. A lot of that money has not been released. It's in the process of how it's going to be distributed and who gets to act on distributing it. And I think we provided you some of that information earlier. Next slide. Workforce issues.
Yeah, Pat, actually, this, Betsy, if before you get into workforce,
ahead.
just maybe a little update on that state stuff too. We're seeing it with our work with other states that there's very few states who have released any plans surrounding their state funding. Many of them have been waiting to see what is going to happen with the federal relief and how to coordinate it. So as Pat mentioned, more to come in the future, and we think more will be available after the federal relief is finalized.
This is Melissa. Let me add just a little bit more. I know there was a question earlier, and I know we've had many inquiries here at the office regarding the FMAP dollars. That was one of the initial pots of money that came down to states. So they increased the federal match by 6.2%. That money came down to states. I think it certainly was the intention when Congress acted on this that it would be used for COVID-related expenses. And we immediately, when that happened, we were working with the administration. And because Michigan, the current state of our economy, they're estimating a $2 billion deficit in the state's general fund and a $1 billion deficit in the school aid fund. The administration and the Michigan State Budget Office and Treasurer's Office has, as Betsy has stated, they have not released any of those federal dollars, and they are essentially taking a position that they're not going to do that until they have the full picture of any other federal relief that could be coming to the states. The state, and particularly the State Budget Office, they are only, unfortunately, primarily focused on backfilling and the state's general fund, the state's checkbook, because it's such an incredible deficit. So we continue to advocate for those FMAP dollars, but to date, they have not released any of those to any healthcare providers. And if we ultimately cannot get relief from the FMAP dollars, then there certainly are going to be opportunities in the CARES Act and then potentially even in a further stimulus packages coming down. So our best opportunity at new dollars at the moment, at this time right now, is the $15 million Pat mentioned. We do have a handful of state legislators that are advocating strongly on our behalf that we do get that $15 million out of the state supplemental bill that was signed. So I did want to go back and just touch on kind of the status of the FMAP dollars.
Thanks, Melissa. It's a good reminder. We're working hard for it. Workforce issues, just quickly. We understand and we've heard much about the crisis in getting workers, and we've heard about people giving what they're labeling hazard pay, $2, $4, $5 more an hour to keep staff. Some staff have gotten nervous to get COVID in their facility, and they don't want to come to work in that. And so there's been lots of issues that have caused the staff are getting sick. Staff are afraid to bring it to their families. So we understand the workforce crisis. Obviously, you folks are living it. The unemployment, the expanded benefit of the $600, some folks get the feeling that they could just go ahead and walk off the job and get that. That is not the truth. You can't, if you're a healthcare worker, you can't do that. So you can look in the DOL or look in the Michigan labor websites and find that information, but that's not there. The FMLA that was allowing extended time off for sick family members, taking care of them, that is also not allowed for healthcare workers. So it's trying to keep the workforce on taking our thing. The other issue on workers' compensation, we're just hearing that, and this is just a foretell of the future, that the worker comp claims will probably go up extensively and concern the rise in that cost. And I think Linda's got a comment on some of the AL workforce challenges.
Yeah, just quickly on the AL side with the FMLA and unemployment and those things, in adult foster care communities or in communities that are exempted from licensure, we don't qualify by definition as healthcare workers, and that's causing creating some challenges for us with the FMLA and some of the other exemptions that are allowed for healthcare workers. We have put in a letter to the governor requesting an executive order that would define those settings as healthcare workers for the duration of the crisis, so that they could have the healthcare designation for those exemptions. But as of right now, that's not the case.
Thank you. The last slide is...
Before we keep, can I jump in for a minute?
One more thing.
Okay.
The last slide we've already done. It's on the payroll tax deferral and the SBA loans. All of that's been covered, so go ahead, Kathy.
Okay, sorry, I just wanted to jump in while we were still on workforce. Want to make sure everybody understands that there are a number of provisions that have been put in place to help you as an employer maintain adequate staff within the building. So first of all, if you have a nurse aide who was going through the nurse aide training program but not able to finish their clinicals, there is a process to grant them a temporary nurse aide registry. Also, if you have someone whose registry is expiring in the midst of this crisis or the state of emergency, there is a process to extend the expiration date of their registry. So their registry will remain active. One of the CMS waivers was to allow providers to hire individuals, train them, ensure that they are competent, so doing skills tests or competency evaluation, and then those individuals can be allowed to work as a temporary nurse aide doing direct care. I want to make sure people understand that with this provision, those individuals will not automatically be given a nurse aide registry at the time the state of emergency concludes. At this point, they will still need to go through and complete a state-approved nurse aide training program and successfully pass their exam to receive their registry. There's been some whisperings around, depending upon how long the crisis continues and how long this provision is in place, that there may be some provision or some granting of credit for the experience and the time that they have worked, thank you, but that nothing official as of this point in time. So you do have an opportunity to hire staff in, train them, and put them to work. In addition, you can bring other individuals in, and again, if you train them, you can have them complete tasks. There's all kinds of things that workers can do to free up your nurses and your CNAs so that they can focus on direct care. If you have nursing students who have completed their training or have completed portions of their training, with the executive order expanding the scope of practice, they are able to practice at a higher level than where they currently are. So, for instance, we had a situation that came up yesterday where a facility has 2 different CNAs who are in nursing school. For those individuals, if they have completed training, they may practice at that level, but no higher. You cannot call them a nurse, but you can give them expanded duties based on their current education. We also have the opportunity to extend licensure, Michigan licensure, to out-of-state physicians and nurses, as well as reinstate licensure for those individuals who have recently retired or let their license lapse and wish to come back and practice. So there's a number of different provisions that have been put in place to help augment the workforce. Okay, and I am done. I'll turn it back to Pat.
Thank you. We have about another 10 minutes or so. I don't know if anybody else, we have any other questions we can answer? I don't know if there were any other questions that came through.
Okay, yep. Here's one. It says with competency validation, which I'm assuming is referring to hiring an individual and training them to be a direct care worker. And that is correct. I've had conversations with Lara to make sure that they understand the federal waiver on this and are in line with it. And they have agreed that the provider can choose the type of education and training that they want to use for those individuals, because ultimately the provider is responsible for determining the competence of that particular person or that particular individual to do the tasks and duties assigned. So just like you would with a nurse aide, when you're putting them through orientation and you do that skills check off before they head out on the floor on their own, you would want to do the same thing with these individuals with the temporary nurse aides.
Any other?
Got anything else up there? Maybe? Okay.
Anything else?
Just a reminder of the slide.
Well, there's a chat that came up, it looks like, too.
Chat?
Can you please expand upon the nursing student skill? Is this based upon class completion, or is it based upon the technical round completion? I'm assuming you mean technical round, meaning the skills, meaning lab time and or clinical time. And honestly, I would be a little hesitant with the nursing students to get very involved as far as the amount of work that you can assign them to do unless you are comfortable with where they have been through their schooling. You have confirmation of the classes that they have completed and the clinical labs they've completed. The language itself is fairly loose on this, so you could make an argument for it, but I would be very careful to ensure that you've got good documentation to cover yourself if you are having those nursing students take on advanced skills and advanced tasks in the workplace.
Don't see any other questions at the moment. Just a quick thank you to Betsy from Plant Moran and helping us out on all this today. And I want to extend a thank you to my co-workers from HCAM and MCAL who have all popped in here and been able to add to this webinar. We would like feedback. You can send it to any of us on staff here or send it to info@hcam.org. That's info@hcam.org. It will get to us and we will be able to know if there's information we need to put out, if this has been helpful, things we missed, things we didn't make clear. Let us know. We will clarify it. Keep getting our updates. If for some reason you're not getting the updates from us, they're going out pretty much twice a day, almost 7 days a week. So if you aren't getting something, let us know. Make sure you haven't got us blocked in your receiving your email. And we appreciate your attendance. Betsy, do you have any other final comments or?
I do not. Thank you.
Thank you. We understand the governor's on at 3 o'clock. We anticipate that she will extend Melissa's got some information on that.
Yeah.
She's going to announce.
Well,
we can jump her.
Watch at 3 o'clock, but your expectation is the governor will extend the stay home, stay safe policy until April 30th. So the original directive was for 3 weeks. That ends on April 13th. She will be extending it till the end of the month, April 30th, where obviously citizens would be directed through an executive order, which is carries the weight of law, to stay home, shelter in place. You got it 15 minutes early.
All right. Thank you all. If you have no other questions, and like I said, let us know if this has been helpful, and we'll try to do this again if it's worth it. Thank you, everybody, for attending today.
Thank you.